Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator, and this is session number 139. A very happy new year to you all, and hopefully by this time several of you have already received your second dose of the vaccine, and in parts of the world getting ready to get the first one. Hopefully it is the beginning of the end. Now, of course, so many of our viewers are from India, and they would be waking up with extreme jubilation with what happened last night at the cricket match at Brisbane. For those who are uninitiated about the game, let me explain to you the involvement of the Indian in the cricket. At one time, close to the ending of the match, there were 127 million live people watching the match which was going on there. And of course, I've been enjoying cricket for the last 50 years. I can tell you this has been the greatest victory. So congratulations. We join all the Indian viewers in their celebration. This morning we have an absolute expert who is Dr. Paul Tierstein, most experienced interventional cardiologist with amazing hands and very intellectual brain to back it up, a person who's been involved in several endeavors which we'll discuss during the case today. Dr. Tierstein officially is the chairman of cardiology and the director of interventional cardiology at Scripps in La Jolla, California. Paul, good morning, very early for you in the morning, and it's a pleasure having you join us. You are joining us. The previous two people were Dr. Antonio Colombo and Dr. Ron Waxman, and you fit the bill exactly right, and we are looking forward to getting a lot of wisdom from you. Samin and Anu, good morning. On over to you and take us through the case.
All right. Well, welcome, Paul. We can see him in pajamas, but hopefully we'll put his mind will be very active, although very early in the morning. But really, thank for him to accepting this our invitation for CCC live webcast, which we started getting a guest faculty to add to additional charm and educational discussion. So with that note, let's go to the slides. So we usually present Paul, the way system is that we'll present the case. And the actual case will be performed by Anu, and then I'll have a time for these are our case supporters from the support point of view, and disclosures are unchanged the same way, and we welcome you as a guest faculty today. So this patient is a 45-year-old male presented with new onset class 3 angina for a few months late last year, had a positive stress test, didn't have any CAD or things before. At that time, his SAQ scored 55. As you know, 100 SAQ means good, 0 is bad. So medication, he was a little bit hypertensive, hyperlipidemia, well controlled on medication, and cath was done on November 9th, which revealed extensive 3-vessel disease, and we'll show you that. And ejection fraction was normal. After heart team discussion, CABG was recommended, but patient strongly declined. And patient was angiogram done outside. So has been managed medically. They added nitrates and ticagrelor to optimize medical therapy, and patient is here for the complex intervention, which showing that angiogram right here.
Yeah.
So we'll show that. Yeah.
So EF, you can see EDP was normal.
Yeah. No, 1 second.
Oh,
we'll go back. Yeah.
About 45% actually had normal LV function when he initially had his angiogram, but now I think over the course of few months with non-CAD, and probably has been having non-QMI also.
No, but this is very important. Just to say, 2.5 months ago, his EF was 65%. By angiogram was normal as well as by echo. So it was 2 tests which were normal. It was not a stress perfusion, it was just the ETT. So over 2.5 years, 2.5 months, ventricle has become sluggish. He did have a very small, admitted yesterday, troponin was small, right? 0.8. So he may be having a small infarct lat. But could be, I expect, all that will be hibernating, as you'll see how extend the coronary artery diseases. No?
Yeah, so proximal RCA, totally occluded here, anterior takeoff, This is the left. Left main actually is, I would say, the segment angiographically non-obstructive, significant disease. In the circumflex, you see a large OM bifurcating. Then there's another OM that's coming early part. Then you have LPL, which has disease. This is the LAD. So mid to distal LAD, I would say short segment, about 8 millimeter total. Then distal LAD disease. Diagonal, which is large, has a ostial about 50%, but a significant disease way further down, which is also bifurcating.
Anu, significantly not much calcification.
Right.
Yes, no calcification.
With that age,
Paul,
we'll take it to Paul now. The comment. Let's go to the slide. So I completed because they will require a lot of discussion and opinion what we should do. So this case, again, was now planned for high risk complex PCI of LAD diagonal and circumflex OM. EF now, I would say we don't have the current echo today, but EF will be around 40% now with extensive 3-vessel disease. EDP was
12.
12. So EDP is okay. So just to sum it up, our OC classification, which we do all the cases, this patient has a 3-vessel disease with intermediate to high risk finding on the non-invasive testing, and more importantly, high syntax score. Only thing is it's not diabetic, and therefore it's appropriate because of the heart team discussion. With that note, now you can take it. We are ready for, we get an opinion from.
Paul, a couple of questions straight up front for you. At the Scripps Clinic, would this patient come as the first choice for CABG or multivessel PCI? That's number one. Number two would be which vessel would you go after first, and what are your thoughts regarding Impella here?
Good.
So lots of thoughts. Good morning. I'm happy to be joining you guys. I'm surprised. I was kind of sleepy. That's why I have my pajamas on still, but the case kind of woke me up a bit. It looks like we're going to have to do some serious work here. The answer is, first of all, it would be nice to have a syntax score.
Yeah, it was 50. Yeah, syntax score was 50 in this case.
50, so that's very, very elevated. And how old was the patient again?
45, young guy. At that time was normal EF. Now it's a mild to moderate LV dysfunction as of today. But normal is actually the young age, non-diabetic. So one advantage here is non-diabetic, but very high syntax score with the few total occlusions.
So this would be controversial. No question that a lot of physicians would send this patient to bypass surgery. I'm going to have to get a little technical help here. For some reason, I only see your screen as a small screen on my machine computer here. So that's why I missed some of that. I couldn't read the writing. But it looks to me like the distal targets are good for bypass surgery. I couldn't really tell too well because it's so small on my screen, but I would have a long conversation with this patient and make sure they understand the risks and the alternatives. But I would offer to them stenting. It's a pretty good case for stenting. You have a totally occluded LAD. It looked like, and if you couldn't, obviously, if you can't get that open, I think you have to reconsider and think about bypass surgery. But let me just look at that LAD while we talk again. I think you're going to get it open again. I have got it on a tiny screen here, so maybe someone can teach me how to make it work on this med and box system. So I would start with the LAD. If I couldn't get that open, I would then maybe reevaluate. But assuming you're going to get it open, I would go ahead and revascularize as much as you could today. His EF is bad, but so far I don't see lesions that are really treacherous. I don't see calcified lesions that I'm going to have to use rotational atherectomy for. I may be wrong. So I might try to do this without support carefully, probably even radially, and see how things go. But there's no penalty to using Impella support with this either. It's it's a high syntax score case. Maybe that would allow you to get the whole case done in one day, one setting more easily. So I think nothing wrong with Impella. I think it's used a lot, but I probably
3.
There you go. That's better. Whatever you did for me, I can see now. Thank you.
Yeah.
So now I can see the pictures. This is great. So
Yeah,
I
let
would
me
do
show
it-
you the let me show the angiogram because I think that's the crux of fluoro, right? So this is the LAD is the crux right here. As you said, yes, we have agreed to have a trial of PCI, and which if we cannot open the LAD, this case actually came from outside
He
to
was an
Dr.
interventional
King.
cardiologist who
And the
referred.
interventional cardiologist referred and has taken 2 consultations outside and came to as a third consult to Dr. Keeney just with the idea that he just does not want surgery. Now question is, if we cannot open, do we go back to that drawing board again if we cannot open the LAD? So that
I
will be
think,
the
you know,
part of the discussion. Yeah.
it is diffuse disease. I mean, it's you know, it's not, maybe it's not a great bypass candidate because there's so much disease in the LAD.
Right.
And this is an
That's
interventional cardiologist himself.
Yeah, the referring was an interventional cardiologist.
Oh,
Your
okay.
distal LAD has lesion. You see that distal LAD has a lesion, so may not be a good candidate for Lima.
Right.
So
And
that makes
diffuse
it
disease of
better
the
case.
circ. Yeah, circ, even the OM, the large OM has diffuse disease.
Yeah. So this is actually not the greatest case for bypass surgery. Now that I can see the screen
Right.
bigger.
Yeah.
So you're going to wire this. Let's talk about the wire. This is kind of a CTO LAD, but it's one you should be able to get through. You might want to, if you get stuck here, you might want to use the polymer jacketed wire. You know, Xi'an black, Whisper, just as a start, and then quickly move to a Mongo if you can't get through. What are we using here?
We tried Fielder, it's not going through, so I've changed it to Gaia 3.
Right now it's a
Gaia
guy.
next.
Okay, so it's a short occlusion. I used to use the Gaia next in this situation, and I've been converting.
Now die.
Yep.
Yeah, beautiful job.
And you give
I've
some
been
die.
converting to start with the Mongo neck first because I just find that
Good.
be a pretty safe wire and a lot of success.
Exchange length run
What you're
through.
doing right here.
Yeah.
I think
Pull back a little bit more. Yeah.
You didn't show me a picture.
Yeah. Okay, pull
Inject.
back. Okay, we'll do it, but no, pull
Yeah,
the
I will.
fine cross back. No, we'll not see it without that. Yeah, now. So you just have to, it looks like in a truly distal, nice position. We just need a little manipulation there.
Okay, pull back a little bit. Yeah.
Yeah, good. That's it. Yeah.
that looks very good there. Paul, almost
220?
universally transradial now.
220 compliant.
Yeah, with we start transradially for pretty much everything. I mean, everything. Occasional CTOs will do by femoral and radial, but we just got. And I was very resistant. For many years I was very
Right.
resistant because I just didn't feel it. I could do complex
The
cases.
fellows now get adequate training in transfemoral.
Well, they do only because of the TAVR program. They do
Got it.
very
Yeah,
well.
yeah.
All of our fellows, do some
Right.
TAVRs, and so they get that. But it's a very good point. The transfemoral art gets lost. So at this point, if you're through the lesion, do you think you're through it, or do you think you're just almost through it?
No, I think we threw the lesion, both of them. Yes.
Okay, so then what I usually do next is I use a wiggle wire, the short wiggle wire, and I use a ton of wiggle wires. It's so helpful. So you can just put a wiggle wire down now, and then all you have to do is pull out your catheter. It grabs the
Pull
walls
back
of
a
the
little bit.
catheter, and the exchange is done much easier. How are you doing this exchange with an extension or with a?
Yeah,
with
no, what? Yeah, we did now we have the exchange length run through, and we are ready with the 2-out compliant balloon 20. And to open it here, they told me that actually the highest user of the wiggle wire in the world is Paul Tierstein. They're keeping the plant open for you.
They sell us over 1,000 of those a year.
Yeah.
Pretty funny. But I mean, like in this case, the exchange goes more quickly, and then of course you've got a wiggle wire down, which makes it easier to deliver equipment, stents and balloons. But there's a lot of different ways of doing it.
And you'll use the exchange length wiggle wire in this case, right?
Use actually a short length wiggle wire.
Short.
Because of the wiggle wire, you'll be able to remove the over-the-wire catheter
Yeah.
without
It's
300. Yeah.
You have to hold it straight, but it's a nice slick trick. My fellow showed that to me. I was using it. I was exchanging the old
Down.
one. The fellows showed me, hey, it holds itself in place. So you're just doing some pre-dilatation here?
Yeah, just
Yes.
a
He's tolerating
PTCR.
He's tolerating this without any kind of
So
support.
far,
correct?
yep. So far, good. Yes.
Can we show the hemodynamics also?
But do you have a right card cath? Is there any, do you know what his ADP is or?
No, EDP was 12. With the LV, we went to the LV diagnostic
Okay, copy.
before the JR, right injection with the JR. And so this is, now we are done. Saturation good, hemodynamics good, as you can see here. It's a 20 compliant balloon. And many times, as you mentioned, that you can remove by the hydrophilic, hydrostatic exchange, that you take a small syringe and you in the back of this over the wire system. Now, only problem which happen
It's
is
a big LED.
that if you have many times that particularly in cases with these CTO wires, they may go slightly anti-grade. So we do that in a non-CTO wire. Let's say I have to use the fielder or run through to exchange. We'll just go with the hydrostatic pressure in the back with an indiflator or a small syringe. But usually with the CTO wires, we are not done because we have one case of perforation because wire went almost 1 inch forward.
Even the polymer coated wires, we don't do that with.
Yeah,
we get
I know.
nervous with those,
Trouble, yes.
because
So now that we see the LED so much
Okay, let's start
better,
putting it down
the diagonal is also fairly
Good size.
good size vessel.
Yep,
So,
yep. So let's put a stent
what-
distally
First
first.
thing to think about in this case,
No,
though,
2 to
is
5.
Whichever you want. Yeah, tell her.
that new 48
Promus.
millimeter stent.
Yeah.
You know the 48 millimeter stent from
2 to 5,
Boston,
24,
So
right?
no, but use synergy because proximally then you can use a 48 millimeter. Because this case, you have to use a long stent anyway. You have
You
to
don't
combine
give a
both of
gap?
them. Yeah.
You're going to send the whole LED
Yeah,
or
but
leave
there's
a
no
gap?
other choice. Now tell me
No.
why would you not stent it? Because it's a
You
completely
still have
diseased
to
vessel.
give a little gap for the lima.
No, but you have to give a gap. Okay, just few millimeter fine. So let's get a distal little synergy and then proximal synergy.
I don't know what synergy is.
Yeah, because proximal should be 48, no?
No, Zions or Promus.
Okay, tell us what the strategy is now. So
I
that
said
we
that
go
2, 5, 24.
2, 5, 24 distally, Promus.
Yes.
Okay, and proximally?
We can go.
Give us a 2.5,
32,
24 Promus.
and maybe a 28 in the proximal lesion. Yeah.
3 or 28 or 32? Okay. Okay, 2.5, we are putting it now in the distal because we still have to do the LAD and then
DAG.
And then how often do you use imaging for a case like this for the sizing and the diameter?
I mean, we rarely use imaging for sizing, but many times we have used it. Most of the time is only in the live case. Here we will show post optimization.
yeah.
Not for a regular case that we would do.
Yeah.
Paul, still with heparin, or what's the mix between bivalirudin and heparin, and more use of cangrelor too?
So if a patient has an acute coronary syndrome, we would use cangrelor or often. Not everybody uses it as much. Dr. Price, my partner, uses it more than most of us. The heparin is what we use. We stopped using bivalve, unless they, have an allergy. We don't really use it anymore. So the data just doesn't seem to pan out these days. So are you using a lot of bivalirudin?
We are about 50-50, about
process.
50-50 at present.
Based on the cuteness of the presentation?
Yeah,
Is that what you?
right, yes. We actually we are not a big cangrelor lab. I know a lot of people do within our group. Some one or two attendings use high dose of cangrelor, but
acute MI we do use it.
Yeah.
Or if there is any interprocedural complication, maybe not otherwise, not routinely.
okay.
So,
Yeah.
I'm sure. So you're going to
28 should be okay, no? See?
You're going to try to put a gap so that if the patient.
Yeah.
Yes, that if he's young, if in the future, if he restenosis, then I think he needs a gap for surgery. No? Now what do you think? You can still leave
Do
a
something
little gap.
distally.
Yeah,
38
but that's
you want?
okay. The
That's okay.
stent
That we are going to
expanded
leave
little
it.
too much
Yeah.
there. You want to smooth out little.
What happened to the blood pressure drop? See that? I think it fell down.
Okay. So
No,
what do you want to do in the middle?
It's gone down.
Yeah.
We will put 38, right?
Okay. 3038? It's a long segment, yeah.
30?
Or 2.75?
275.
Okay. 2.75, 38?
Yes.
Okay.
So Anu, proximal to the stent which you have placed is where you want to preserve some part of the mid to distal LAD for a possible future
Lima.
Lima.
Yep.
I mean, they do stentectomy. There are a couple of surgeons who do stentectomy, but I think as long as possible, if you can avoid it.
Yeah,
And
we
after this, what I'll do is we'll go into the diag, then into the circ.
And the right, was the right occluded as well? I was. I don't know,
Yes,
small
right
screen.
is occluded.
Route is actually very big vessel, and it's completely occluded. Maybe it will become part of the another webcast.
Symposium.
In few months,
Right.
yeah, in a
If you
few
want to
months,
see it,
we'll
let
bring
me
him
show you the
back.
RCA now. This
Yeah.
is the RCA, mega RCA.
That's a big vessel. Big vessel.
Very big vessel. Yeah.
I want to show one thing. Hold on. And if you see here, I did take a look at this. Look at the collateral. So
Right.
Short segment. Yeah.
Yeah, and so that also brings up the point that you need to be careful with your guide catheter on the left side and with what you're doing today because you're providing the collaterals to the right coronary.
Yep.
So if we have
Really
a problem with
such extensive disease in a non-diabetic
Yeah.
is truly unusual.
It's positive family history. Ilba.
okay, now
Actually,
some
that
diag,
too also
some
in the
diag.
old age. Yeah.
Confirm?
Nothing young people. I say just it is very surprised, and for him also knowing that all just few months disease. I mean symptoms. So very reluctant. So he did not stop places till he found out that something can be done percutaneously. And you know this is going on as you mentioned. The angiogram was done 11/9 in New Jersey. So more than 2 months, 2.5 months has been floating around. Get a nitro.
so that was the gap you left. It's a small gap.
Yeah,
You're not,
right.
Yes,
yeah.
yes.
Purposefully. Yeah, purposefully leaving that gap.
Before.
Yeah.
I've never seen this before. So your surgeon has very small fingers. I mean, it's a.
Ready? Go.
I might have sent it down to a certain percent. I said,
Go to the diagonal.
It looks okay. It looks okay.
Fielder again.
Fielder for the diag now.
Yeah. So diag is
What do you
same
think?
2O balloon.
But you don't need 20, no?
Okay, the 2O12, 15. Yeah.
12 maybe.
Would you have
Twelve.
are you doing bifurcation technique here, or are you just going to slit that?
No, I think no. We'll stent the distal diag. We'll balloon it. See how the distal part of the diag looks, and
Fielder.
then we will just balloon it. We don't want to do bifurcation.
Yeah.
Okay.
Anu, planning to
Maybe-
do
maybe
something. Go ahead, Paul.
The ostium of the diagonal, maybe is that what you're thinking of doing?
Yeah, ostium we can just I think balloon cut it something.
No, and again, remember in this particular case, knowing that he is going to come back for
Multiple.
second visit or maybe third visit, that one, RCA, whatever some unstented area, if need to be taken care in the future, we can always take care. The point is, if we start putting a stent in the diagonal, we thought at the ostium, it is going to pinch some of the LAD disease. So maybe it's a moderate ostium, leave it. Just take care of the subtotal mid portion of the diagonal and just put a short stent there and then watch it for the later. Yeah.
Blood pressure low? Or
No,
what
this is
happening?
fluctuating. This is the problem in the hemodynamics, which we had to call somebody today. Last week also was very big trouble.
So it's the measurement that's the problem, not the blood pressure.
Yeah.
Do you want to put
Right.
the hemodynamics up for our screen, or do you want?
Can we show the hemo on the screen
Hemo
on the
should show
side
it.
so that they
Because
keep watching?
non-veg blood pressure is 130/90.
Die. So I see which branch
I
I'm
see.
going to.
You have a problem with your monitor
good.
there.
Yeah. But
Oh,
this has
we
been
do.
a trouble.
I think there's a loose wire. That's what it doesn't look like a bubble to me. It looks like a loose wire.
Okay.
Anu,
Okay,
this
fine.
is the fielder wire down the diagonal.
Yes.
Yes.
Okay.
You take a picture now?
Yes.
Okay.
Okay.
Let's
Ready?
take a picture, yeah. Yep, good.
Paul, the Scripps Clinic is a very large brachytherapy center.
You need to give
Yeah,
beta
we're
block.
doing about 150 brachytherapies a year.
Right.
EKG has changed.
Yeah, we did a thorough review of that with Ron Waxman, and as I researched for his presentation, I had also figured out
You beta
that
blocker?
you are very active, and he mentioned that during the case too.
There was a time when Ron and I were the only ones doing radiation,
Yeah.
Yeah.
when DEF started. But now there's about 30 sites around the country. It's,
Actually more than that, much more
they're
than
now
that.
like 59 in New York
58,
itself.
yeah.
They became in New York they became 5, and after U2 in 2012 we resurrected our program. We are doing the same 100+ cases now, referred, and we dedicate days, Tuesdays and Friday.
Go.
same situation. You still have to get the radiation oncologist to come over, right? So it's a
Yeah.
little bit.
Down.
Yeah.
So the next thing that's going to happen with that,
2.25.
of course, is the drug-eluting
Go up here.
balloon.
Yeah.
2 to 5, no?
Yeah.
Distal is
2 to
not the
5.
large one.
But radiation will
Put it
again
down.
plummet, I predict.
Yeah.
And then but ultimately it has a role.
Go up here. Ostium a little bit.
That we do with the stent
Cutting?
balloon. Stent
Okay,
balloon
done.
cut. Good.
Okay, now let's decide on the stent diameter and length.
Yeah. Just that area.
Yeah.
2.25 maybe.
No, just we are,
You mean
if we are doing
distally?
it, that, if
No,
we are
no,
just
I want
putting
to
a
go
distal,
back.
yeah,
Here we didn't dilate.
yeah, we have to go to a little high pressure there. It is a 2O balloon. So question, if you want to get 2.25, right? 15 or 2.5 at this area.
Yeah.
It's a 20 atmosphere, now 22.
You want to 16.
Okay. 2.25, 16. Yeah. Good. And we'll leave the ostium alone. Let's play the last one. Good. Ostium, because remember, once you do ostium, guaranteed you'll pinch the LAD, and then we have to put a 2-stent approach. So I think this is okay to leave it with a moderate disease. And I think what also I would say, at least the ischemia trial also showed that many times even this tight angiographic lesion, which we used to be very much worried about, that's okay to leave them as long as you're doing good medical therapy. So not every lesion we are stenting and so. And I know that many people, once the drug-coated balloon will be available in these questionable cases, the latest the trial Picolito 2 and so showing that maybe, particularly in the small vessels, drug-coated balloon may be a viable option. Paul, what do you think on that?
I am
Yeah,
eagerly awaiting all the data we're going to generate and see what happens. I think there's definitely a big role for drug-coated balloon. I've been involved with a sirolimus-eluting balloon technology for over a decade now that we hope to get into a clinical trial this year.
Good. Yeah, we need that. We definitely need, and particularly it looks like that in the coronary, the mortality is not an issue. The recent meta-analysis showed also, while there has been an issue in the peripheral, at least there is a no mortality signal in the coronaries of even at a 3-year plus follow-up of these drug-coated balloons.
So, Samin, several viewers have
You want to go here?
Yeah.
expressed
Yes.
exactly the same suggestion that you use the coated balloon for the distal and even leave the LAD for a future Lima. So good, all good thoughts.
Okay, I'm going to take out these wires, okay?
Yeah, take it out.
Good.
And
You want the
again,
nitro first
I've
one?
been
No.
getting
Take a
so
picture.
many congratulatory notes about the cricket all over again. This
Wow.
is big celebrations. The
to
vessel
the
looks
caudal.
very good.
Yeah.
Samin, another couple of questions about do you plan to do anything to the very distal part of the LAD?
No.
No, that's
Right.
diffusely disease. I think we should leave it alone because there's no end to this start and end of this vessel.
Yeah.
And
Where do you start, where to stop?
another suggestion about using IVUS to evaluate the ostium of the diagonal. All good suggestions. Keep them
Exactly.
coming.
Go to sir. We have 2 balloon again. Yeah. So now this wire is gone.
That wire is gone.
Yeah.
So I'll
Get
take
a new
this wire
field
out,
wire.
SS,
Yeah.
and then we'll
Good.
keep it.
So now we are going to give nitro and getting ready for the circumflex. With that note, we can go a little bit on the clinical presentation, right? Get few our
Slides.
didactic.
Good.
for a few minutes?
I'll continue here.
No, but let's take a picture so we decide.
Okay.
And let's go to the slides again. No, you know what? Let's take the last picture and ask Paul that what he will do. Go back to angio, please. Yeah. Let's show the last picture. Can we play? Paul, what would you do now? Knowing that this is the case, very diffusely disease in the LAD system, what else you do in your practice? This is your patient. What else would you do now?
Well, at this point, I would do IVUS just to see how it looks and make sure everything's fully expanded. That's one thing I would do differently.
Okay.
Uh,
Perfect.
Your choice.
Good. So we'll do the IVUS. You want to do IVUS now or later? Later.
Slow you down, but that's what I would do. And
No, okay. So we'll do the IVUS. Yeah. We'll do the IVUS. Okay, let's go to the angio. The slides now. We can pass on the angio and we'll do. And so two topics we always talk about. One are the latest issues in coronary field. This time I'm going to talk a little bit about the coronary CTA and cardiac MR, which has been quite a bit coming because a lot of patients, the doctors, everybody asking us on the data of the Scott Hart, rapid CTCA and GARDA CAD. And then we talk about one focused review of the month, that is the long-term outcomes in patients with severely reduced ejection fraction undergoing PCI or CABG. So this is the first one is basically CT. As you know, the CT clearly is increasing, the value of the CT, the use of CT, and there are multiple papers have been done by the NICE criteria in the Europe. CT has become a first-line treatment for screening. So we don't have it in USA yet, but outside it's the first-line screening test. Not the calcium, the only calcium score. And CT, progression of atherosclerosis and various levels correlating from the what happens in the coronary with a no coronary disease and early inflamed coronary plaque in the fatty tissue, the non-calcified ruptured prone plaque, which is the positive remodeling, and then plaque rupture and acute event. And of course, the fractional flow with the CT FFR, which we do nowadays. So all those have added into the understanding of the CT in our diagnosis and management of coronary artery disease. As shown here, the classical example with a minimal, mild, and so people always concerned that what happens, the CT could be wrong. I can say one thing for sure, what we learned, if the CT is negative, no coronary disease, it is absolutely, there is no coronary disease. If it is positive, sometimes because of the calcium and positive remodeling, it may be, stenosis may be a little different. And then, of course, it can tell you, based on the IVUS, our necrotic core, because of the low attenuation plaque, napkin ring sign, spotty calcium, all can be very well identified on the CTA. Now, also, various imaging technology. Fatty index, basically low fat and high fat, with the special testings, the plaque quantification, and the wall stress, and FFR CT calculation, as we know. So all those are the additional emerging technology which are getting into our life. So Scott Hart was the first one to see patient with a stable CAD that you do a standard of care or you do a CT angio, and basically found that 5 years, 3.9% death and event MI occurred in the standard care group compared to CTA by 2.3. So 1.6% decline. So 61, you have to treat 63 patients to reduce one event of death and MI. An individual, and you say, well, maybe by the CT you did more revascularization. Answer that is no. We did not do more revascularization, as you see here, Cath, PCI, and CABG in these patients. Initially, little more the Cath CTA group, but then it caught up in the standard therapy group. But most important is on the right side, the preventive therapy. Once you do CTA, you do exercise, you enforce more preventive therapy compared to a standard care. Anti-anginal, patients get scared, give them the picture, put on the fridge. So before they open the door of the fridge, they are very concerned about the plaque. So clearly the preventive strategy becomes more aggressive once you do a CTA and tell the patient that you have a disease. So this trial used of a CTA in the Scott Hart, in addition to standard care in patients with stable CAD, resulted in a significantly lower rate of death from coronary heart disease and MI at 5 years, without resulting in significantly higher rate of coronary angiography or coronary revascularization, and benefit occurred because of more preventive therapy, more anti-anginal medications, and so. Now then, in AHA, they presented this trial called rapid CTCA. I don't know why they call it CTCA. I think it should have been CCTA, but they called it CTCA. And basically it was, what are the role of the CT angiography in the emergency room suspected or provisionally diagnosed acute coronary syndrome. They took a patient with a high-risk CAD, presented into the lab, to the emergency room, either troponin positive or have a known history of CAD or have an abnormal EKG. And they randomize the patients, basically done in UK, randomize the patients to standard of care or do a CTCA. Basically, invasive coronary angiography, as you CTA performed in 87% of cases at 4 hours, good diagnostic accuracy, and of course, obstructive disease and non-obstructive disease shown here. And then, yes, by doing the CTA, you did have a higher invasive angiography, but coronary revascularization was similar as shown by the Scott Hart also. This is 12-month data. And what did we find? That there was no evidence of difference in any of the individually key secondary outcome relating to all cause coronary heart disease or cardiovascular death or non-fatal MI in using rapid CTCA in the emergency situation in high-risk acute coronary syndrome. So this was a little surprise. And they went to the individual groups. Still, there was no benefit of any subgroup. So overall, the conclusion basically was that there was no difference in subsequent hospital admission or outcome of these patients. And even 1 year rather, you have more length of stay, higher healthcare cost, and so. So clearly, to sum it up, rapid CTCA did not improve the overall outcome and diagnosis of acute coronary syndrome, the high risk, intermediate or high risk. It is good for the stable CAD, maybe in the low risk chest pain to rule out or rule in, but definitely management of acute high risk CTCA did not make it through. So last one in this field is this gadobutrol, which is the gadolinium family, enhanced cardiac magnetic resonance imaging for detection of CAD. So basically, until now, we have the main test, which is the SPECT. SPECT shows, which is radiation, and SPECT detect coronary disease, the extent of disease in addition to CTA, which I have mentioned. But SPECT is the, at present, gold standard test to understand the extent of CAD. The only question comes, what about you don't want to give radiation? Because there is a radiation in can you do a MRI, cardiac MRI, and that is this the field of the GADA CT, which is the various groups CAD, GADA CAD 1, 2, and basically done with the vasodilator. You can see a perfusion. So stress perfusion, you give the gadobutrol 0.05 millimole per kilogram. Then you give adenosine or regadorsen to do a vasodilatation, and then the rest MRI to see a late gadolinium enhancement and really test if there is infarction or ischemia. And ischemia basically means there is a CAD. And basically showed that CAD occurred in about 28% of cases. If you have 70%, because all these patients have a coronary artery, coronary angiography also. If you take a 50%, it's 37.5% of patient disease. Now, they had a very nice, I would say, evaluation of unblinded and more important, multiple readers, up to 6 readers, and show the high sensitivity and specificity in tunes of 80+%. And that is in a wide variety of operators. Is very, very positive with a OC of 0.87, fantastic. And these actually show the case examples of that. And so, which is more so, I would say, for the nuclear imaging person. But the message is that you have another test. Vasodilator stress and rest myocardial perfusion CMR and gadolinium enhancement imaging, and has high diagnostic accuracy for CAD in phase 2 and 3 trials, and supported the CMR use gadobutrol CMR in now. So if FDA approved, until now it was not FDA approved, and so therefore there was a nice editorial that we have good stress perfusion CMR may play a key role. Now it was not compared against SPECT. So that we do not know which one you should do. But clearly we have now another non-radionuclide test, not less radiation nuclide test in our armamentarium. Okay, with that note, I'll stop here and we'll ask Dr. Keeney where we are now. Anno?
Samin, can I ask you, how old are you?
I'm 63, 64 in May.
So did you get your CT angiogram yet?
I have done 4 times CT angio in last 25 years. 4. Yeah. So far 3 were good.
Every time
what about you?
The hospital, right? Every time you get a new scanner, you get a free scan, right?
That's it.
Paul,
and
Paul, what about you? Have you got?
I got one 4 years ago, and I have a 20% LAD, a 30% circumflex, And it really changed my behavior. I got my HDL is up to 99, my LDL is down to 50, and I'm probably going to go in Praluent. I worry about this.
With the
I
use
do
of
a lot of self-examination.
statins, of course, or just
Don't
lifestyle
dilate it
modification.
till you show it. Yeah.
I take some statins, but I actually get
Upper branch.
really bad muscle spasms.
Upper branch.
Over diagonal?
So I'm
No,
going
on
to
the
probably go on
upper
Praluent,
branch,
but I'm
not-
I
Yeah,
change my diet, do a lot of aerobic exercise.
Very
but
good.
the angiogram, but to Samin's point, the CT angiogram really motivated my behavior. It really changed.
Yeah. That is the key. And now with the COVID time, we put a little extra time in ourselves. Now, Anu, tell us now, while we are having a discussion of our personal life and the CT angios, she's doing her work now. Okay.
Was easy to cross, did not require any other wire, just with the fielder. But you see that I got into the upper branch. Plan is let's dilate and then maybe we can wire into the lower branch also later.
Okay.
You see
And
that?
then
I mean,
So you're going to do just ballooning here, or are you going to try to do
Yeah.
bifurcation stenting?
no, here I think we'll just again balloon stent. That's it.
The small.
If I can get into the lower branch, that's preferable. It's a larger branch. Upper branch is diffusely diseased. I want
not
to avoid
planning to do anything to the circ in
Go.
the AV groove. Leave that
that. No,
alone.
not this time.
Yeah, that we leave alone. Yeah. So if we can escape, get a LPL or second branch, but
This
these two
guy-
branches here. and
Very
then maybe
important. I
LPL.
think we should not be stenting a lot in this patient. We don't know how he's going to
Go a little
respond. If he starts restenosing, he has to go for
I go
surgery.
a little further. No? The
So,
bifurcation
Paul,
level?
I want to,
think I
I had reminded myself to share this wonderful and inspiring anecdote with our viewers. Now,
Well.
often you'll have a
Down.
patient's family praying for you. Often your wife is, you're concerned about a difficult case. She's praying for you, but you had the Pope praying for you.
I did.
Good lower
in
branch.
1991.
Lower branch, right?
Yeah. Yeah.
Tell us about that, Paul, and how you took care of, what do you remember, recollections about Mother Teresa?
Well, she was down in Mexico in Tijuana, and she took ill and was being cared for by my first fellow, Dr. Patricia Abenal, down in Tijuana. And she was in congestive heart failure and had a pneumonia and was sent up to Scripps where coronary angiography. I mean, I'm probably nowadays I'm violating HIPAA talking about it, I guess. But those days was okay. So the coronary angiogram showed severe 3-vessel disease. We had we were doing some research with the Palmar-Schacht stent. It was still very much not approved by the FDA, and we had something we would call compassionate use. Our emergency use that is, of course, now very tightly regulated, but then it was not. If it was on your shelf and you needed it, you could use it. So I dilated her right in circumflex with balloon angioplasty. They all look good. The LAD did not look good. The LAD was a little calcified and it just wasn't a good result. And so I took a Palmar-Schacht stent off the shelf and did that really made it a beautiful job. And when I went out to talk to the sisters who were waiting in the room, they let me know that the Pope had my name and was praying for me.
Wonderful.
Really got my attention, I have to say. After which, Mother Teresa blessed the stent, and the Palmar-Schacht stent became known as the sacred stent.
Yeah.
After that, it was kind of nice. It was an amazing experience. She was in the hospital for a month and got to know her. Then I went and visited her in Calcutta, we started some pretty significant relationships with her organization. It was great. I was a very lucky young interventional cardiologist in 1990 to have that experience.
That is most inspiring story, and I'm glad you mentioned it here again.
Balloon support.
Anu, your plan is also to, after the circ, interrogate with the IVUS, the LAD?
LED, yeah. So that's our plan, yes. We are all ready with that.
Want to go to
12 balloon again.
Paul,
Give me a little
right moment in the case to also talk to you about something which greatly involves interventional cardiologists, maybe various other specialists too, the maintenance of certification. I was reading about it. I have known about your interest before, but this is far more than a passion. I mean, this is some of the aspects I understand truly in some ways there is a restraint on our trade. This is extremely difficult matters, yet it is something which is affecting our practice, affecting our reimbursement, payment, extremely stressful, so much time and effort involved. So what exactly is the National Board of Physician and Surgeons, the NBPAS, doing, and how could individual physicians get more information?
So the NBPAS, National Board of Physicians and Surgeons, and just go to nbpas.org to find out about it, or Google my name and you'll find it, or Google MOC and you'll find it. It was an organization I started in 5 years, actually almost 6 years ago now, to provide an alternative to the continuing certification requirements. This is when MOC came out. I started doing MOC and I was very frustrated, like many of us. It did not seem to have much value, if any. It was very complicated. It was very onerous, and it was expensive in that, for an interventional cardiologist, it's about $500 a year with 3 boards. And you multiply that by the number of cardiologists around, or internal medicine folks around, we're talking about a $30 or $40 million tax that the American Board of Internal Medicine gets to levy on us just for internal medicine every year with MOC. And I just didn't think MOC was valuable, and it was a waste of time. So we started a new company called the National Board, and the National Board provides certification to physicians who have maintained 50 hours of CME in their specialty over the past 2 years. This aligns well with what the states want. The physician also has to be in good standing and have privileges. You can't be kicked off your medical staff, and we vet all this very carefully. The idea being that if you have initial board certification, we're not against the initial board certification, but if you do your initial board certification with an American Board of Medical Specialties member board, like cardiology, any internal medicine specialty, surgical specialties, dermatology, anesthesiology, all the specialties. If you have that initial, we will give you maintenance certification, continuing certification at a much lower cost. The cost is $169 for 2 years. And without the onerous test taking, we're very much against test taking. We don't think multiple choice tests have a big role once you finish your initial training. This has been very successful. We've certified now almost 9,000 physicians. I'd urge you to support us by, it's a not-for-profit. And by the way, none of us are getting paid. None of the doctors get paid. There's about 15 well-known doctors on the board, many of whom are cardiologists, because I know a lot of cardiologists, and none of us get any payment for this. We don't want any payment for this. We just want to try to right this wrong. I went to the Department of Justice twice, and they wrote a position paper. It's called a white paper, claiming that MOC, that by requiring MOC, the American Board of Medical Specialties is a monopoly, which they are. And so what we're trying to do now is attack this by getting hospitals and insurance companies, payers, to recognize alternative certification boards. Just like they used to only be JCO for hospitals, now we're looking for multiple sources of certification. So that's our goal, and we've been pretty successful. I think we've been successful in getting the American Board of Medical Specialties to change their ways as well, and so their certification system is no longer as oppressive. They're doing online testing of what they call walk-around knowledge, and they are doing a better job, but they're still charging a lot of money, and It's a bit annoying how much money they charge and how much money they make to do something which has such little value, in my opinion.
Look, clearly, Paul,
Wow.
this is there's a lot of interest, and as you were explaining it, I have 2 emails already here. They want to know the website address again.
NBPAS, National Board of Physicians
.org?
and Surgeons. .org.
Okay.
Yes. Or just even again, if you Google MOC, you'll find it soon. And we need the support.
Proximal has become a little more.
You know, we can take donations,
Maybe
but we don't really
spasm.
want donations. We'd rather you just sign up for it, and that way we have more members.
Look, we'll spread through our vast network. We'll spread the message, and good luck with this endeavor. Paul, you've been watching the case. What
Yes.
are your thoughts? Would
So
you
it
have
looks
done
like
exactly the
we got an
same?
issue here, right? We've got an issue with the upper branch.
Right.
Yeah, upper branch is a little subtotal, small, but we just,
the wire
yeah.
came out of it. Just take us through that. Did the wire come out? Did sort of?
No, we
pulled
took it
by-
out. After we
Yeah.
placed the stent,
was
we
jailed wire,
stent jailed wire, then we took it out, yeah.
So it was
Or
jailed.
I think
and
leave
then
it alone.
across.
I think we
Yeah.
leave it alone now.
A little pinched, right now.
Yeah.
Yeah, print. 16.
Pinch with TB2 flow.
And we'll give little vasodilators and see how things are.
Okay, go up here.
Yeah, question is there is a proximal mild disease which looks a little worse now. We have to see.
Vasodilators a lot.
Yeah.
Okay, good.
Yep. Good.
I'll take this wire out.
Okay. Yeah.
Give
Let's take a little
vasodilators
nitro.
now.
1 second.
Give nitro everywhere, then we IVS LED.
Yeah.
Give me a
Yeah. You have the run through there.
short run through. Short run through, yeah.
Okay. So what we are going to do, we have done this circ branch with one of the second branch LPL we can do off camera. So the circ is revascularized, and then we do the IVS of the LED. Okay. Let's take picture. The guide is there? No. Guide came out.
Okay, now,
Bit other view.
okay. I think we're okay there. Wow.
You need to go. Do you want to go to the LAO view to see it?
Yeah, will be good.
Yeah,
Yep.
Be okay.
Good. Ready? All right. So that's okay. There's a lot of still diffuse disease left. We go to epicrania. Yeah. So, but looks okay. I mean, there is a proximal disease, and then we'll try to work it out with that OM or OM2 or OM3 or LPL. With that note, while we're getting the IVS ready, we're going to show it in. I just want to just complete so we remain in line. We can go to our presentation because we are in time so far. The second is the focus review of the month. That is a long-term outcome in patients with severely reduced LV dysfunction undergoing revascularization, PCI or CABG. So this is a study from Core Health Ontario Clinical Registry. They took the patients EF less than 35 and had a LAD disease left main or both and multivessel CAD who underwent PCI or CABG. And those patients then were followed for 5+ years, and then they have a propensity match, knowing that there will be so much disparity with the 12 characteristics, they match this. So I was a little surprised that even 30-day outcome in these patients favored CABG, as you can see here, with the MACE and of course the mortality 4.8 versus 4. And we know that even in the Excel trial, the 30-day was a little better outcome in the PCI, and of course at 1 year were equal, and then after that went to CABG. But the key is that even in these patients with LV dysfunction, you ready with IVS? Yeah. So in that clearly that even 30-day in this match registry, whichever way they could do, and there were 30-day, there were 11% revascularization. I don't know how they counted. Maybe it was a stage intervention. How can you have 11% revascularization in the PCI group? But that is what the data are, and MI of 7.8. That again becomes different than what was the criteria of myocardial infarction. But overall, with the outcome point of view, as you can see here, patients were followed up to 8 to 9 years with an average of 5.2, a median of 5.2. The PCI did worse than CABG. And these are the individual endpoints. Primary outcome, death, MI, stroke, 30% occurred in the PCI group and 23.3 in the CABG group. Cardiovascular death, MACE, stroke, definitely in favor of PCI, 4 versus 6% in CABG, but revascularization, hospitalization, MI all were against, or I would say in favor of CABG. These are the individual endpoint, except I said the stroke, and then of course even higher the hospitalization in the PCI group. Then they did that you say subgroup, whether LAD only, left main only, diabetes, no diabetes, revascularization, complete versus incomplete. Don't do it yet. 1 second. Don't start 1 second. Yeah, we do live. So very quickly, so basically showed that no matter what it was, subgroup, all favored CABG in this propensity match. So basically, then in this study, higher rates of mortality and MACE were seen in patients who received PCI compared with those who underwent CABG. And then, of course, the findings may provide insight to the physician. And of course, nice editorial to say that many things you need to consider quality of life of the patient. So because many of these patients are physically deconditioned and so forth. Maybe those are the high risk which went for PCI. Those confounding factors were not taken care in the registry. Just to say, we have similar data from Korea on the iris main registry that patient based on the LV dysfunction, whether it's a normal, mild, moderate, or severe, that outcomes, as you can see here in the adjusted hazard ratio on the right side, the moderate LV dysfunction or severe LV dysfunction do better with the CABG compared to PCI. So there is clearly a credence to this aspect that once you have LV dysfunction, again, there is no randomized trial, but once you have LV dysfunction, CABG may be better in complex CAD or left main as shown here. But at the same time, we tell patient go for surgery. But clearly there are a lot of other anti-CABG websites now. There is one I'm sure you know about, a Uber of interventional cardiology, pushes stents over surgery and claim that even if you have multiple coronary blockages, find a person who can do the PCI, because they compare bypass surgery with the stent, which we all know that of course these are many of them against the guideline. But like this particular case, if somebody does not, after making a decision, looking at all the pro and cons, and decides not to go for one approach versus other, I think patient is the ultimate decision maker. So just to sum up, our take-home message is the CCTA in detection and management of stable CAD, thumbs up. CCTA in management of high-risk acute coronary syndrome, thumbs down. GADA CAD, CMR in CAD detection, stable ischemic heart disease, 2 thumbs up. And of course, the long-term 5-year plus outcome of patient with severely reduced LV function and CAD demonstrated lower mortality, MI, MACE, and hospitalization, but higher strokes after CABG compared to who underwent PCI in all subgroups of CAD. Confounding factor of patient's overall physical condition, frailty, and personal choices should ultimately decide the choice of revascularization in heart failure reduced EF. Randomized trial is not done yet, but I think it's urgently needed. Quickly, the 3 questions. Following statements are 2 regarding the CCTA in evaluation and management of CAD, except very good prediction for future cardiac events in stable CAD, good in identifying high-risk plaque, good in predicting physiological significance of a lesion, very useful in predicting CAD in ACS patient, and newer CCTA technology can identify coronary inflammation. Answer is D. Acute coronary syndrome, particularly high risk or intermediate to high risk. Then GADA CAD CMR studies evaluating CAD detection and perfusion showed the following, except high diagnostic accuracy to detect CAD, highly predictive of future cardiac events. So far, GADA CAD CMR assessment is now FDA approved. Gadobutrol imaging compound has excellent safety record, and GADA CAD CMR interpretation is highly consistent among various imaging readers. Answer there clearly is, we have the imaging study, we do not have the cardiac event data on the GADA CAD CMR yet. The last one, following are the findings of the long-term outcome in patients with severely reduced EF undergoing CABG versus PCI, except mortality after PCI, higher MACE rate after PCI, higher stroke rates after PCI, higher heart failure hospitalization after PCI, and higher revascularization after PCI. We all know that stroke rate is wrong. It is higher after CABG. So with that note, Anu is ready here. The wire has been advanced, and we can put IVUS on the main screen. And as Paul wanted, we are doing the imaging to see optimization of our stent, and starting with the distal part of the stent.
Okay, start the
Okay, this is the
distal stent. Yeah,
Okay.
well opposed.
Okay, start full back.
Yeah.
They should put the floor on the side also.
Small vessel. This is distal, right? No dissection, and well expanded, This is a distal stent, expanded.
Well expanded, loud.
Well expanded. Go to proximal.
Put the fluoro on the left side also.
Proximal. Good, expand it.
Any dissections?
No,
No dissection. I think it's a gap. And this is a
no, this is a
branch.
gap.
Right.
Yeah,
Yeah.
This is a gap. Little bit plaque, but enough lumen.
Yes, we know that.
This is
Okay.
the proximal edge of the distal edge of the proximal stent. Yeah, very expanded.
Well opposed.
Well opposed. Yeah, well expanded. Good one. Still good, expanded.
Maybe a little squeeze here. Huh? Yeah,
No.
there may be a little squeeze. Yeah.
Yeah, still good. Maybe still in the proximal edge.
Okay,
Fluoro.
no dissection.
Yeah, no, it's still good expansion. Yeah, and
Yes,
this is the
good.
proximal edge. Yeah.
And
it's no
now you'll see the
dissection.
diag.
It's
That's a
yeah,
diag.
It's a diag. Yeah. Okay, can I stop here?
Yes, stop.
Okay, stop here.
But Paul, you tell me, but I think the proximal part of the stent may get a little trio balloon just to optimize. Lumens are expanded well, but could be more expanded. I mean, it's opposed, but may need a little extra expansion. We'll look into it. Idea there is we want to get our lumen stent area maybe 5.6 plus, and so. Yeah,
The
tell
other
us.
thing I noticed is your circumflex proximal to the stent. If you IVUS that, you might want to put a stent proximal to the stent in the circumflex.
Right. We were thinking about that. Okay, but from the LAD point of view now,
Yeah, you might want to put a bigger balloon in there. You used 275, I think, right?
we use 275. Yeah, here. So we can
Come
just
back.
post dial it. Yeah.
No, I don't know. I think
In that
it's well
area.
opposed.
Yeah, well opposed. Yeah.
Look at
Your phone's just gonna be a little
step
bigger.
up. There's step up and step down
Yeah.
in angiographically.
Okay.
Yeah, we're just
Something to
looking
leave
at the stent in relation to the lumen, to the size of the vessel wall.
Yeah.
I mean, it's acceptable. It just could be, it could be better, and that might reduce recurrence rate. That's why. It's not, there's no.
You want
Good.
to?
Yeah, trio. So okay, we can do the offline. Yeah, we can do
So
offline. now.
20
Yeah, we can end
high
it now.
pressure balloon. Okay, end it.
Huh? Yeah.
End it.
So okay, so we'll just do as we learned from this IVUS, that area around 2-3 o'clock, we'll dial it with a trio to optimize the results. And I would say that we are coming down to our end of the discussion of presentation of this case, and very beautifully, elegantly done. Clearly, the proximal circ as
Tell him to put
as
main
he,
screen.
mentioned that definitely the proximal circ could be may get that OM proximal part of that OM may get additional stent. We'll look into that aspect, but I think various steps, step by step presentation of this complex case and multi-vessel revascularization was done with a limited amount of dye contrast.
Yeah, so I
and-
can tell you the total, radiation, AK was 0.7, okay, and DAPT was only 73. Total contrast 140 cc and fluoro time of 26 minutes.
Anu, what would be the plans for this patient going forward?
No, I will see him in the office and I will bring him back for the right coronary artery, total
And-
occlusion.
And then decide
that-
on the proximal to the mid circ also, or
at that time. Other thing is also, give him couple of, maybe 2 months and bring him back for another webcast, the totally occluded right coronary artery.
Yeah.
Well, you did it
Okay.
very quickly too. I'll give you credit for that. It went by very quickly. And what kind of equipment do you have to give you such little radiation dose? Is that Philips or who's? what kind
Phillips.
of-
No,
Yeah,
Phillips.
Phillips. Yeah.
Philips has
Okay.
very low dose. Yeah.
Paul, thank you so much
good
for
job.
joining us so early in the morning. And
I gotta go back in bed now. I gotta get back to bed.
You may start dreaming about this case.
That how would you do it? That how would you do it yourself? Of course, many others. I really thank Paul and of course all our viewers for this excellent the part of it, asking the questions, appropriate questions, and so, and keep just motivating us to do better and better, meet all the requirements to uplift this educational mission. We thank you very much, and with that, we end from our side, from the Cath Lab, and Samir, for you to conclude.
Well, wishing you all a very happy new year. Stay safe, and we will see you on February 16th for the next session.